Okay, welcome members of the IFSO community to the 6th IFSO Journal Club on the 6th of December 2018. And we will discuss a recent article published in Obesity Surgery. It is authored by Dr. Sergio Barrichello from the Gastrointestinal Endoscopy Unit at the University of Sao Paulo in Brazil. This article has been selected by our own members on a Facebook poll. And I'm very happy this article has been selected. My name is Bart van Wagensveld, and I'm currently located in the UAE. And Dr. Barrichello, welcome from Brazil. What time is it now?
Here is midday.
Midday, good.
Yeah, almost. Midday and 15.
Yeah, maybe. Good to tell that you're a bariatric surgeon with huge experience in endoscopical procedures. So the name of the article, laparoscopic greater curvature application and laparoscopic sleeve gastrectomy treatments for obesity. And it's a systematic review and meta-analysis of short and midterm results. So again, welcome. And just out of interest, Dr. Barrichello, why did you choose this subject?
Well, but this subject was chosen because, first of all, we need obesity is a chronic disease with no cure. We need to find a lot of options to improve the treatment, and I think that many countries people don't have much money, and options with low cost could be amazing, and gastric application is one option. We know that sleeve gastrectomy is much more popular, and but I think that is very important to open the options, and this is one of the reasons that we choose this article and this subject. And as well, we are endoscopists, so we do endoscopic plicatures, and maybe in the future we can compare the surgery of greater plicature with the endoscopy to do plicatures in the stomach. So I think that is very correlated issue. So this inspired me to make this article.
Okay. Well, thank you very much. You prepared the slides of the most important results. So please, could you take us through the article?
Well, thank you, Bart. First of all, I want to thank Dr. Almino Ramos and all people of IFSO and members of IFSO to be with us and enjoying this webinar. I would like to thank my co-authors that they were very important in this paper confection. And as I have already said, obesity is a very big problem around the world. So we are talking about, my article is laparoscopic greater curvature application and laparoscopic sleeve gastrectomy treatment for obesity, systematic review and meta-analysis for short and mid-term results. First of all, you can see in the slides the characteristics of the two procedures, and you can see the gastric application and this. Oh, I can point it. You can see here a line of the suture and another line. So this is an example of gastric application with two folds. And oh, I'm so sorry. And the other hand, in the left side, we have the famous sleeve gastrectomy. Well, our research was done in Medline, Embase, Cochrane, Scopus, Lilacs, BVS, and Senahol in Gray Search. The Gray Search we performed in ResearchGate, Google Students, and books, theses, and many other source of search. We do it in accord with Prisma. Our review in the Prospero, it's a very important international database, and our meta-analysis, the inclusion criteria were completed published clinical trials, no restriction for language, for a year or for a year of publication was applied. The search resulted in 17,423 records. Only 10 full texts were assessed for eligibility. And in the end, just 8 studies were included in meta-analysis. You can see that we have a lot of articles, but we can put in our meta-analysis just 8. The informations that were analyzed was hospital stay, operative time, odd mass index loss in 6, 12, and 24 months, percentage of excess weight loss in 3, 6, 12, 18, 24, and 36 months, loss of hunger feeling, complications, symptoms, and morbidities, improvement and remission. In the first slides, you can see in this chart the analysis of hospital stay. There's no significant difference between gastric application and the sleeve gastrectomy. You can see in this chart that the figure touched the bar here in the middle of the chart, that it says that no, we don't have a significant difference. In the operative time, we don't have as well a difference between gastric application or sleeve gastroplasty. We have to consider in this time what techniques were used to do the procedure in sleeve gastrectomy. Some groups used to do a second fold over suture in the line of the stapler, and other groups don't do it. So this operative time can vary because the techniques could be different. Well, this is a very important part of the meta-analysis, because we analyze the BMI loss with 6, 12, and 24 months. We can see in the 6 months we don't have a big difference between the procedures, but in 12 months and 24 months we have a great difference between the gastric application and sleeve gastrectomy. So this is important information, because the BMI, it's a very important thing to think about when we will choose some procedure, the results. And excess weight loss with 6, 12, and 18 months, we can see in the chart that all of the information sleeve gastrectomy had it's better. You can see here in the graphic the figure doesn't touch in the bar. It's here as well, and so on. And the results of 24 months and 36 months we can analyze very well because we have a very not so much numbers of patients and a high level of heterogeneity. So this data, it's not consistent. So what we can say for sure is that in the 12 and 18 months, we have a great result with sleeve gastrectomy. Talking about the improvement of comorbidities, we can say that no difference was found between the procedures. So we can clearly say that we didn't have any difference between the procedures. But when we are talking about just going back a little bit, hypertension improvement, hypertension remission, and diabetes improvement didn't have any difference. But here in this side, you can see that diabetes mellitus remission it's very important because in sleeve gastrectomy is much better than when in gastric application. And sleep apnea, we didn't find any statistical difference. Talking about the symptoms, abdominal pain and sialorrhea. Just in sialorrhea, we have the difference between the procedures, and we can say that in patients that was undergone to gastric application, they had much more sialorrhea. That it's something that can make the patients not so happy, but not big problem. And when we compare nausea and vomiting, we didn't find any difference as well. So the procedure, and talking about the symptoms, just symptom that had some different was sialorrhea. This is a very important thing to say that when comparing complications as stenosis, thromboembolism, bleedings, and leaks, we didn't find any difference. So in thesis, we think that maybe sleeve gastrectomy could get more leaks, but we didn't find it, and we can say that it's the same thing. We don't have a statistical difference. Loss of hunger, it's another thing that sleeve gastrectomy showed better, and so it's another important thing to say. Well, Bart, I think the results were this, and now we can discuss a little bit about it.
Okay, thank you, Sergio, for this this overview. This is very clear and solid information. I have to congratulate you and your team on the methodology as well, because this is a very thorough article. What did surprise you most? Did you? I think you expected some outcomes. What was the most unexpected outcome? This article.
Well, Bart, I think that the most unexpected result was about the complications, because we expect that sleeve gastrectomy could present a little bit more complications as bleeding or leaks, because we have stapler line, and gastric application, we don't have this kind of action, but it was the same. So we need to consider this information as a very different that I was expected. I need to confess that this is the most unexpected thing that I found.
And if you look at the groups you compare the sleeve gastrectomy and the plication group, you already mentioned in your introduction that another question might be comparing to endoscopic procedures.
Yeah.
So wouldn't it be right to compare endoscopic procedures with the sleeve with the plication? That's one question. And how important do you think it is to compare to the gold standard? Because the plication still is not considered as an established procedure, but it's an investigational procedure. So how do you look at that aspect?
Yes, but first of all, as we have already said about the costs of the procedures, and I think it's important to compare the applications with the gold standard that is sleeve gastrectomy, because we can compare an endoscopic procedure with a surgical a surgical procedure, because we know that surgery is much better, and we face good results with surgery, and endoscopy we need to choose very well our patient. So in my opinion, we need to present to the patient all options and select very well this patient. For example, if you have a patient with a lower BMI, the surgical gastric application could be a very good idea. And if the patient doesn't want to have surgery, the endoscopic application should be a good option as well. So I think it was in this way that I feel about the gastric application for surgery and gastric application for endoscopy.
Okay, thank you. And just about the price, what you mentioned earlier, that is one big or major aspect to choose for plication, and I think it differs in different countries or continents, but apparently in Brazil it's an important aspect to choose for a much cheaper procedure. Is it really that much cheaper?
Actually, when we think about the gastric application, greater curvature did by surgery, yes, it has a very low cost when we compare a sleeve gastrectomy. But when we are talking about endoscopy procedure, endoscopy, I think it's more expensive than the sleeve gastrectomy. So we need to make things clear. When we are talking about the surgery, gastric application, it's cheaper. It's low cost, has low cost. And but the endoscopy application, it doesn't have. But I think that we need to present a lot of options for the patient. One, I think, when everybody knows, only 1% of the candidates of bariatric surgery have the surgery. So if we present a lot of kind of surgeries and even endoscopic procedures, we can make this number grow a lot and offer the people new possibilities. Some patients doesn't want to cut their stomachs, and if you say to them that they will not to cut, just to suture, maybe it could be much more, how can I say, they can feel better and accept the surgery, and yes, they will have a very good results in most of time. Gastric application presents great results. I think it's something like this, Bart.
Yeah, yeah, and then you consider it as a permanent procedure rather than, for example, a balloon, which might be a temporary solution for as a non-surgical option. So basically, I've two more questions, Sergio. The first question is based on these results, how do you look at the gastric plication? Is it for you now more closer to an accepted procedure, or would you still consider it as investigational?
But personally, I think that gastric application could be an accepted procedure because we have the weapons against the obesity, and we can have this more weapon and offers this to the patient. The results, it's not so bad. And we know that the long-term result, it depends a lot on the patient way of life. So if we have a good follow-up with the patients and nutritionists, dietitians, psychologists, and the surgeon follow this patient for a long time, maybe we can do the results that it's not so good when compared to sleeve gastrectomy, but maybe we can do these results be better than we have now with the gastric application.
Yeah, I think that's an important point. The pre and after care of the patients, and but basically you say that the procedure is safe, at least not less safe than a sleeve gastrectomy and feasible.
Yeah.
So my other question would be, what follow-up study would you suggest?
For the gastric application to have a better information, do you say, Bart?
Yeah, that's what I mean. Yeah.
Okay. I think we need to have results for 5 years, at least 5 years to say something else. But obesity is a chronic and continuous disease. When the patient has surgery, he isn't cured. We just treat it. So if we can do something that the patient has a long time, 5 years, 6 years of well-being and health, maybe the mindset of the patient could be improved, and the expectation of good results can to be improved as well. And so, in my opinion, when we are treating obesity, we need to look to this issue with carefully, because surgery is the gold standard to treat today, but we know that a lot of treatments and technologies and drugs is coming. So in my opinion, all we can do to have more thing to combat this challenge is much better.
Okay, thank you very much, Sergio. I think this was very nice to meet you, the author behind the article, and I'm convinced that there will be many more questions to be asked, and I invite all the IFSO members to participate the 6th Journal Club on the 6th of December, and well, I'm really enjoyed this interview, Sergio, and thank you very much for for your efforts.
Well, thank you, Bart. It was a very big pleasure to talk to IFSO members, and we wait for everybody in 6th December. Goodbye.
Okay. Thank you. Goodbye.
Bye bye.